Nursing care during labor and birth. The LPN provides care and support during labor, but they are under the supervision of the RN. However, it's really important for the LPN to understand the processes of labor and birth so they can recognize abnormals. First of all, we need to know what clues to look at if birth is imminent. In other words, it's going to happen like any second. A woman comes into the facility claiming to be in labor. What signs and symptoms might indicate she is very close to giving birth? So first of all, we need to determine which stage of labor she might be in just by observing how she looks. What are her actions? If she is in the advanced stage of labor, we're going to quickly move her to the labor bed and assist the RN with performing a vaginal examination. As far as our admission history and physical, we just need to focus on her current status. We can get all of that history after delivery as necessary. I will tell you that most facilities will have medical record copies of the women who are anticipated to deliver at that facility. So a lot of that history can be obtained just by looking at the medical record, and we don't have to continue repeating all of those questions or issues when they come in face to face. Do you realize that the maternal health history and physical assessment will include the obstetrical history, her current labor status, the medical surgical history, her social history? What are her plans for labor and birth? Is there anything in particular that we need to be doing for her? What are her desires and plans for the newborn? We need to look at the prenatal record and then complete that head-to-toe physical assessment. As far as the labor status, we need to document the contraction pattern, determine the fetal status. Excuse me. What position are they in? So what is their lie, their presentation, their attitude, the position, and the station? We do the vaginal examination to assess dilatation and effacement and the fetal progress through the birth canal. Once again, the LPN will assist, but they do not perform vaginal exams, which are only performed during labor when necessary. We try not to do a vaginal exam more frequently than every hour if necessary, but sometimes it is necessary. So again, with the fetal status, it is a priority nursing intervention. We look at the fetal heart rate, and we can do that with continuous monitoring, a fetoscope, or just a Doppler. What is the risk assessment? So has their amniotic sac ruptured yet? We do know that rupture of the membranes will increase the risk of infection. Was it a spontaneous rupture? And we need to look for obvious signs of rupture, doing the nitrazine test, checking to see if there's continuous fluid coming from the vagina. We need to assess for vaginal bleeding and ask about any problems that may have been experienced during pregnancy. Ask if there were any prenatal fetal assessments completed and what were the results. We do a quick physical assessment of mom. This is very crucial, and this includes getting her vital signs and looking for any signs of infection, high blood pressure, or shock. We try and determine those labor and birth preferences. Do they have any special requests for labor and birth? Do they have a written birth plan? Are there any specific questions regarding preferences and needs? And reassure mom that she can change her mind anytime. Be aware of cultural differences and preferences, and then support the woman's choice regardless of what our personal beliefs are. Routinely, we're going to give a full report to the healthcare provider after we complete that admission history and physical. This helps determine if the client will be admitted or if we will send them home in false labor. If we are going to keep them, we probably will need to get IV access started and get some lab work drawn as indicated by the facility. This usually will include a CBC, their blood type, and RH factor. We may do the VDRL or RPR at this time, or the rubella titer, the ELISA, vaginal and cervical cultures for gonorrhea, chlamydia, or group B strep. And we may do a urinalysis. A lot of that will be dependent on, was that done with prenatal care, and does the physician want that at this time? I did mention briefly that with amniotic fluid, the nitrazine paper, one clue to labor beginning is the rupture or leaking of amniotic fluid. I will tell you that sometimes women think maybe their water has broken, but actually they may have unknowingly urinated. So to determine if that fluid is really amniotic fluid or vaginal secretions or just urine, we test that with a small strip of the litmus paper. If that litmus paper turns green, it's urine. But if it turns blue, that is an indication that it is amniotic fluid. Symptoms of impending delivery will include mom is doing the grunting or the moaning sounds. She's bearing down unintentionally. Maybe she's sitting on one buttock, or she's telling you the baby's coming. She will have that deer in the headlight look, like, this is happening, I don't know what to do with it, help me, I need help. Or if you're looking at the perineum, you may see bulging of the perineum or crowning of the fetal head. One way we determine the fetal lie is to do the Leopold's maneuver by palpating for the fetal small parts, which would be like the legs and the arms. Then we also palpate for the head and the back, and this helps us determine the best place to auscultate the fetal heart tones, because fetal heart tones are best heard through the fetal back. Question. Mrs. Jones, a G4P3, in other words, 4 pregnancies, 3 deliveries. She has come into the labor and delivery suite, and she tells the admission nurse that her water broke 2 hours ago and she feels like pushing. What is the first assessment the nurse should make? The nurse needs to determine if birth is imminent. So how do we monitor the fetal heart rate? The general characteristics of the fetal heart rate, especially if they are in conjunction with maternal contractions, will give us clues as to the fetal status. We can do intermittent auscultation of the fetal heart rate, and this is done with low-risk pregnancies. Basically, we monitor when they come in for 20 to 30 minutes just to get that baseline, and then we can use the fetoscope, Doppler, or the external fetal monitor intermittently for 1 full minute through full contractions If abnormalities are noted, then we would apply the fetal monitor for continuous monitoring. We can also do the continuous external fetal monitor, which is the most common indirect method. Although sometimes it can be difficult to get a consistent tracing depending on mom's position, the position of the TOCO transducer, and the position of the fetus, and is mom moving a lot. Some monitors do now have telemetry units that allow for wireless transmission of the fetal heart rate patterns, and this allows women more freedom of movement. They can actually get up and walk, and we can still monitor. A fetoscope is similar to a stethoscope, and it amplifies fetal heart tones. It is non-invasive and has the lowest rate of false alarms of fetal distress. If you look in your slide on the upper right-hand picture, this is a picture of a fetoscope being used to auscultate fetal heart tones. It has no adverse effects for the baby, and it does not restrict the mom from moving freely or using water during her labor, and it can be done on an intermittent monitoring schedule. Drawbacks of this method is it cannot be used when continuous monitoring is truly medically indicated, and it does require more intensive one-on-one nursing. The Doppler is an electronic fetal monitor that is used for intermittent monitoring. It is also non-invasive, and it requires more intensive one-to-one nursing because you have to stand there and hold the probe on mom's belly to be able to get the fetal heart tones. It does pick up movement and reflects that movement in sounds, but it is not able to identify what the movement is. However, with the external fetal monitors, these are machines that have been around since the 1960s, and originally they were designed to improve clinical outcomes, but supporting data is pretty sparse. I will tell you that there has been a proven increase in cesarean section since routine use, often due to false alarms. Nurses may panic when they start seeing some indications on the monitor that the fetus may be in distress. Same way with the physicians. I'm not going to say that happens with everybody, but it is a proven fact. They can be used to monitor the fetal heart rate and uterine activity through digital readout and graphical printouts. In other words, we're going to get a strip that is showing us exactly what is happening with mom and baby. It can't detect movement just like the Doppler other than the fetal heart motion, such as fetal movement or maternal activity, or even blood flow through the umbilical cord or the maternal aorta. But like the Doppler, it's unable to identify what the motion is. The TOCO transducer is part of the external monitor, and it has a pressure-sensitive area. We place this on top of the fundus of the uterus, and every time a contraction is felt, then it pushes on that sensitive area, so then it's reflected on the strip, and some numbers that show up on the external fetal monitor showing the increased pressure in the uterus. So basically what happens, the uterus pushes outward against mom's anterior abdominal wall with each contraction. Again, movement other than uterine activity can also register on that monitor, and we don't always know if it's maternal movement or fetal movement, or if it is the uterus contracting. Uterine activity is sensed through the woman's abdomen, and it's useful for observing the frequency and duration of the contractions. But the TOCO cannot measure the intensity of the contraction or the resting tone of the uterus. And sometimes this can be important information. Different things that will affect the TOCO is the fetal size. The uterus does not push firmly against the abdominal wall with each contraction if the fetus is on the smaller side. If mom has a lot of abdominal fat, a thick layer of abdominal fat can reduce the appearance of the contraction. Mom's position, once again, different positions can increase or decrease the pressure against the TOCO. And the location of the TOCO. It is best detected where it's strongest and where the fetus lies, usually over the fundus. So with internal fetal monitoring, we use the fetal scalp electrode. It is an electrode that has a little sharp spiral needle-like projection at the end, and we kind of corkscrew that into the skin in the fetal head, and that gives us a very accurate fetal heart rate. So they're beneficial for clients who are difficult to monitor with a fetal external fetal monitor. And fetal or maternal movements do not interfere with the accuracy of the fetal heart rate. However, it does not necessarily tell us what contractions are. With scalp electrodes, these are placed by a physician or a trained RN. And again, they're placed directly on the fetal scalp, but not over the fontanelle. The client has to be dilated at least 2 centimeters, and of course the membranes have to be ruptured. And it has to be placed over the bony prominence, again, not over the fontanelle. We don't want to place it on the fetal face or the genitalia either. It is contraindicated in clients that are group B strep positive or HIV positive. So it is invasive. The risk for infection is slightly increased. It does have to be grounded to the mother in order to get an accurate reading. And it must be removed if a C-section is needed. To remove it, we just basically unplug it from where it's grounded, and then we turn it counterclockwise and it comes right off. The intrauterine pressure, or the internal pressure uterine catheter, IPUC, is used to measure uterine activity, and this one does measure the contraction intensity and the resting tone. Again, the membranes have to be ruptured and the client has to be dilated. This one is placed by the physician. It is a solid catheter that has a pressure transducer in the tip, which may also have an additional lumen in it where we can do an amnio infusion. Let's say the fetus is showing signs of distress, or we're having issues because there is a low amniotic amount in the uterus. We can actually instill fluids through this catheter to help relieve some of those issues, and it goes directly into the uterus. So both types of the IUPC senses intrauterine pressure and increases the intra-abdominal pressure, such as coughing or vomiting. The sensor in its tip will measure the hydrostatic pressure from the amniotic fluid above the fetal presenting part, as well as the pressure from the uterine activity. This fluid-filled catheter can be used for the amnio infusion, low amniotic fluids, or if we have meconium-stained amniotic fluid. The internal pressure catheter measures intensity as well as frequency and duration, and it is very helpful for VBACs or in clients that are receiving oxytocin. This is, again, something that the LPNs are not going to be doing anything with, but again, you can assist in monitoring of the client. So how do we read fetal monitor strips? If you look at this strip here, you can see some fainter lines and you can see some darker lines. Each dark line is 1 minute and each small box is 10 seconds. The top part of the strip is the fetal heart rate, and the bottom portion is where the uterine contractions are recorded. So the fetal heart rate baseline is going to be the fetus's average heartbeat. We round it to 5 beats per minute, so within a 5 beat range. Excuse me. And we measure over 2 minutes of clear tracing within a 10-minute window to get that baseline. And we like to look at the fetal heart rate between maternal contractions. Once 10 minutes have passed, then we have our baseline. So it is important for nurses, LPNs, or RNs to recognize reassuring and non-reassuring signs in order to get help when it's indicated. With the baseline fetal heart rate, again, we measure that in a 10-minute time frame. We want that heart rate to be between 110 and 160. This is considered normal. We also want to see what we call variability. So we want to see fluctuations of the fetal heart rate from the baseline greater than 6 beats per minute and less than 25 beats per minute. So if you look at this strip up here, I'm going to say that the baseline is going to be approximately 130. And if you look in the middle of the strip, you can see several elevations in that baseline above 130, and it goes greater than 15 beats per minute, and it lasts longer than 15 seconds. That is what we consider to be good. Variability shows us that the baby is normal at this point. It's tolerating the stresses of these contractions quite well. So again, that normal fetal heart rate baseline has variability. What it's showing is oxygenation is adequate, which will assist this fetus in adapting to or tolerating the stresses of labor. It also evaluates the function of the fetal autonomic nervous system. It is the primary indicator of adequate fetal oxygenation. So we want to see that up and down movement. We want to see it lasting longer than 15 seconds and at least 15 seconds above or below the baseline. If they're absent, we have no fluctuations of the fetal heart rate. It would be 5 beats per minute or less. Minimal is, it would be pretty much a flat line. Minimal is less than 5 beats per minute. Moderate is 6 to 25. And marked is above 25 beats per minute. So major deviations from the normal fetal heart rate, tachycardia would be anything over 160. If it's over 180, we would consider that to be severe. With bradycardia, if it's less than 110, moderate would be 80 to 110, severe less than 80. Absent or minimal variability, And for this to be concerning, that abnormal rate needs to continue for at least 2 minutes. If it's just a periodic change, we don't get really up in arms about it. We continue watching, but we don't necessarily start panicking. Periodic changes are going to occur in conjunction with uterine contractions and episodic changes. One change we may see is an acceleration. Accelerations are always good, always. I'm going to show you some different examples of these periodic changes in a few more slides, so just bear with me. Accelerations, again, are 15 beats above the baseline and last for at least 15 seconds. We associate accelerations with fetal movements. They are reassuring signs of fetal well-being, and they do indicate a well-oxygenated fetus. In other words, they are always good. They may accompany fetal movement, they may accompany a contraction or vaginal examinations where we actually run our finger across the fetal scalp and we stimulate it. Other periodic changes would be early decels, late decels, variable decels, or prolonged decelerations. With early decelerations, there are no interventions that need to be done other than continue to monitor. I will tell you, however, that you may want to make sure that everything is ready for delivery, because chances are things are getting close. With variable decelerations, what happens with these is we have compression of the cord. Whether that cord compression is continuous, frequent, or just intermittent, we need to relieve that cord compression. And we can do this by repositioning mom or assisting the healthcare provider with an amnio infusion. Basically, this can happen if we do not have enough amniotic fluid in the uterus. And I'll tell you, just an FYI, that the body will continually replace the amniotic fluid, but it may not replace it fast enough to be able to avoid these variable decels. With late decelerations, it requires aggressive management. This is starting to show us that our fetus is no longer able to tolerate the stresses of labor, that it's losing those reserves it has of oxygen and energy to be able to continue this process. We position mom on her side, especially the left side. We start oxygen through a face mask. We discontinue any oxytocin if there is any going. We may give those tocolytic drugs which help relax the uterus. We would increase the rate of IV fluid such as LR to expand mom's blood volume and improve placental perfusion. And then we notify the physician as soon as possible. If the non-reassuring pattern is severe, other staff members need to begin preparing for immediate delivery. If vaginal delivery is not imminent, a C-section may need to be required. We may also need to get extra personnel ready because we may need to do some neonatal resuscitation. We should identify the cause of the reassuring pattern. So evaluating mom's vital signs, really important. Reposition that tocotransducer or the ultrasound transducer if necessary, and perform that vaginal exam so we know exactly the status. Signs of an increasingly distressed fetus would include the absent accelerations, a gradual increase in fetal heart baseline, a loss of baseline variability, late decelerations begin to occur. Decelerations gradually increase in the amount of time, and it takes longer for the baby to recover. Persistent bradycardia and/or death. So this is what early decelerations look like. They start with a contraction and end when the contraction's over. So if you look at the bottom, you see mom's contraction. If you look at the top, you see the fetal heart tones. You can see a deceleration or a lowering of the fetal heart rate basically occurring at the same time the contraction occurs. So it kind of mirrors the contraction. The nadir is usually going to be the greatest at the contraction peak. So that's going to be the greatest change in the fetal heart rate. Early decels usually have a subtle onset because once again they mirror the contraction. They indicate fetal head compression, and this is a normal vagal response in the fetus as pressure is put on the fetus head. So basically, if you imagine the fetus is moving down through the birth canal, additional pressure is being placed on the fetal head, so this increases that vagal response, and that creates the early deceleration. They are not a sign of fetal distress. Like I said a minute ago, it can indicate that labor is progressing quickly and delivery may not be too far away. It is benign and it requires no intervention beyond continuing to assess labor and assessing fetal heart rate. This is a picture of the late deceleration. Late decels begin after the peak of the contraction, and they do not return to baseline until after the contraction ends. They're a sign of uteroplacental insufficiency, and they have to be addressed. In other words, it is indicating baby is not getting adequate oxygen from the placenta. It's also a sign of fetal metabolic acidosis. So corrective interventions are required. We consider this to be abnormal. It is a non-reassuring sign, and we have to address it quickly. So if you look at this slide, you can see mom's contraction on the bottom. You can see the fetal heart rate is approximately, the baseline is about 140. The heart rate begins to decelerate after the contraction has reached its peak, and it continues to stay down, and it does not go back up to the 140 range until well after the contraction has started. This is showing a sign, this strip is showing a fetus that is not tolerating the process of labor any longer. It's beginning to be distressed, and it's going to require some emergency intervention. So basically, there's a deficient exchange of oxygen and waste products in the placenta, which is that uteroplacental insufficiency, and that results in the late decel. Once again, late decels are a non-reassuring pattern, and it suggests that the fetus has a reduced reserve to tolerate the recurrent reductions in the oxygen supply that occur with every contraction. Causes of uteroplacental insufficiency might be acute, such as maternal hypotension. In other words, all of a sudden mom's blood pressure has dropped. Causes of late decels include that hypotension. It can also be hypertension, because remember, excuse me, mom's cardiac output can be decreased with hypo or hypertension. Maybe the uterus is contracting too frequently, so baby does not have adequate resting tone in which to recover from that lack of oxygen. It may be due to a placentae abruption or a placenta previa. maternal diabetes, severe maternal anemia, or maternal cardiac disease. So this is a picture of variable decelerations. Variable decelerations are different than variability. Remember, variability is just a change from the baseline, and it can be either up or down from the baseline. With variables, they occur because there are conditions that are reducing the flow of oxygenated blood through the umbilical cord, and this results in variable decels. Maybe the fetus has reached out and grabbed the cord and squeezed it. Maybe the cord has gotten trapped between the fetal shoulder and the wall of the uterus and compressed it. Maybe we have an umbilical cord prolapse in which the cord has been compressed and the fetus is no longer getting that oxygenated blood. So basically, with a variable decel, if we have an abrupt decrease in the fetal heart rate that goes down at least 15 beats per minute and lasts at least 15 seconds long, and it takes less than 30 seconds to reach the nadir. In other words, once again, that is the lowest or the greatest change in the fetal heart rate. If it takes less than 30 seconds to get as low as it goes, this is a variable deceleration. Again, variable decels are a sign of cord compression. They may be non-periodic. In other words, they occur at times that are unrelated to contractions. So once again, causes: umbilical cord compression, that prolapsed cord. Maybe we have a nuchal cord, meaning the cord has been wrapped around the baby's neck, or the cord is wrapped around other body parts, or we have oligohydramnios, which is an abnormally small amount of amniotic fluid, and we may potentially have a knot in the cord. Prolonged decelerations, excuse me, is basically a late deceleration that lasts for an extended period of time. So we have a change of at least 15 beats per minute in the fetal heart rate, and it lasts over 2 minutes, but less than 10. If it lasts 10 minutes, that's considered a change in the baseline. So less than 2 minutes, or less than 10 minutes, but over 2 minutes. This also is a non-reassuring sign, and it warrants the need for intervention ASAP. This is just another picture of some of those decelerations or the changes in the fetal heart rate. Documentation, we know, is always going to be completed in the medical record, but understand that we can make notes on the fetal monitoring strip. However, we have to then transcribe those to the medical record as soon as possible. It does help keep documentation accurate because on the fetal or the monitor strips, time is noted, so we can tell exactly what time something occurred. However, don't make marks on documentation that draw attention to potential problems. If you look at the strip on the left, this one is drawing attention to potential problems. So that is not something we should ever do. However, if you look at the strip on the right, you can see that a sterile vaginal exam was done at this time. Mom was turned to her left side, and she was dilated at 5 with a -1 station, and she is effaced 90%. The external fetal monitor strip will become a permanent part of the client's medical record. So document on it appropriately. So true or false? Early decelerations are benign periodic changes. This is true. So what does the nurse do during labor? How do we help take care of mom? Remember that first stage begins with the onset of labor and it ends when the cervix is dilated to 10 centimeters and it is 100% effaced. Remember that the first stage goes through 3 phases: the latent, the active, and the transition. LPNs can help monitor maternal vital signs, mom's hydration status, and provide maternal comfort measures. She can help, or he can help mom cope and provide supportive care to the mom and or her partner. Monitor the fetal heart rate and monitor the uterine contraction pattern each time the fetal heart rate is assessed. She can also monitor the status of membranes and or assist the RN or birth attendant with vaginal exams. So in the latent phase or early labor, this is the onset of true labor. The cervix is going to dilate to 4 centimeters. Contractions are typically 5 to 10 minutes apart, and they last maybe 30 to 45 seconds, and they're pretty mild in intensity. At this point, mom's pretty easily distracted. So basically, we're going to assess her routinely, maintain safety, and provide comfort as necessary. Get her vital signs every hour, make sure she stays hydrated, make sure those membranes have not ruptured. If they have, we monitor the status of that or any amniotic fluid. We're checking to see if we have a trend in her vital signs. Have they changed in any way? If we give any medications, make sure that you monitor the fetal heart rate. Fetus is going to be responding to medications pretty much the same way mom does because, again, most medications will cross that placental barrier. So if we give mom an analgesia, we know that it's going to lower mom's heart rate, it's going to lower her blood pressure, it's also going to lower the baby's heart rate. It may put baby to sleep just like it puts mom to sleep. So we need to be watching for that. And we also need to watch mom's psychosocial state. Encourage her to move around as her physical and medical status allows, and change position frequently. She should never lie on her back. And we need to watch, once again, the fetal heart rate if medications are given, and encourage her partner to be active with her, walk with her, help her through this process. We should also relieve anxiety, which encourages verbalization of any fears or uncertainties, answering questions. That also includes the birth partner. So we provide teaching and help encourage successful coping strategies. We need to promote comfort, and this can be done through ambulation, the changing of positions, other comfort measures, or even just distracting her. And reinforce any prior teaching. You know, what can she expect during each phase of labor? What are her options for pain relief? The frequency and purpose of nursing assessments. How to work with the labor process and not fight against it. If she fights against it, it is only going to be more painful and it will cause it to last longer. Those breathing and relaxation techniques, and encourage that birth partner to be an active participant in this process. Then we move to the active phase, and this is active labor. The cervix will dilate from 4 to 8 centimeters. Contractions are more often at every 2 to 5 minutes, and they last longer, from 45 to 60 seconds. They're also moderate to strong in intensity. Mom is not easily distracted during contractions. She wants to rest and kind of tune things out in between those contractions. And during the contraction, a lot of times she's focused inwardly. The fetus begins to descend into positive stations. The labor progress is assessed through vaginal exams, psychosocial assessment, and assessment of the partner. The assessment of the fetus is done at least every 30 minutes, and mom's status at least every 30 minutes. Provide pain management. How is she coping? We can use non-pharmacological methods or pharmacological methods. Promote effective breathing patterns. This doesn't necessarily take away the pain, but it's a distractor, and it does induce relaxation. So the more relaxed she is, the less tense, and actually a little less pain is felt. Each mother may have their own personalized method to cope, and it's also important for nurses to prevent infection, so hand washing. Frequent vaginal examinations are discouraged. Again, unless we're seeing signs on the fetal monitor or in observations of mom, we don't want to be doing these greater than every hour, and we do these with sterile technique. In the transition phase, excuse me, we still need to get that data collection. We're going to be promoting pain management with non-pharmacological methods, no narcotics. Maybe we do an epidural. We assist mom with coping, accept behavioral changes. Some moms can get pretty verbal through this phase. They can get very loud. They can get very angry or upset, or maybe they're very frightened. They are not the same woman that they are otherwise. It's important to support mom through the fatigue and encourage her to relax between those contractions. Get her in an appropriate position and support her with pillows as necessary. Have music playing in the background. Make sure the partner's not getting too tired out, that they are also taking breaks. Danger signs that have to be reported immediately. If mom's blood pressure elevates significantly, if we have a low or suddenly decreased blood pressure, if mom's temp is above 100.4, if amniotic fluid is green, cloudy, or foul smelling, this can indicate meconium has been passed in the uterus and may indicate some fetal stress. It can also indicate we have an infectious process going on, which could be a poor outcome for both mom and baby. If we see non-reassuring fetal heart patterns, if we have prolonged uterine contractions that are lasting over 90 seconds in duration, if the uterus is not relaxing between contractions, if blood is heavy or bright red from the vagina, or mom reports unrelenting pain, pain in the right lower quadrant, she begins having visual changes or difficulty breathing or shortness of breath. These are all signs that we need to call the healthcare provider. So these next two slides show you the different phases and stages of labor, what mom may be feeling, what is actually going on and what mom can do in addition to what her partner can do. So when planning care for a client in the latent phase of labor, what is one primary goal? We need to make sure mom is safe. So true or false? Your client is in the transition phase of labor. One of your nursing interventions will be supporting the woman's coach through the woman's fatigue. This is false. Okay, so now we've moved on to the second stage of labor, the delivery of the fetus. This begins when the cervix is dilated to 10 with 100% effacement and ends with the birth of the newborn. The fetal station is usually 0 to +2 at this point. Focus is on providing physical and psychosocial or psychological support to the woman as she pushes the fetus through the birth canal. Excuse me. We need to assess mom's vital signs and the fetal heart rate, monitor those contractions, and evaluate mom's psyche. How is she coping with all of this? There is a process that is called laboring down that allows the body to work to assist moving that fetus through the birth canal versus active pushing. For example, back when I first started nursing, when mom was dilated to 10 centimeters, I don't care what station the baby was in, mom started pushing. And this often resulted in increased C-sections. It resulted in trauma to the birth canal and or the perineum. It resulted in mom tiring out or the fetus not tolerating the stresses of labor. Where if we allowed the body to labor down and push that fetus through the birth canal to where we were at a strong positive station, then mom had to push less. Baby was able to tolerate this better. Mom got less tired, etc. We had better outcomes. So it decreases complications and decreases the need for an episiotomy. Nurses need to promote effective pushing despite mom's fatigue. So we coach her through this as she's pushing. Comfort measures are still going to apply, and we assist her as needed. If she is just really tired through 1 or 2 contractions, we just do not encourage her to push. We let her rest. Effective pushing techniques. We have that Valsalva pushing where mom holds her breath and she pushes with everything that she's worth. Or we have the open glottis pushing, which she can moan or yell or let out some noises, or she's actually learns to breathe while she's pushing. That is better than the Valsalva maneuver or the urge to push method. So she doesn't push until she feels that urge to push. Preparing for the delivery of the newborn, nursing judgment is going to depend or determine when that is done. A lot of times we will go ahead and have the delivery cart set up that has all of the instruments that might be necessary, all of the drapes, etc., the cord clamp, and so on and so forth. We set that up when mom is in active labor. It can be open for about 8 hours prior to delivery. If it goes over that amount of time, and this will be facility specific, of course we cover it with a sterile drape, but if we go over that recommended time, then we have to break it down and open up another cart. So to prepare for the delivery of the newborn itself, again, closely monitoring mom and fetus, maintaining those accurate delivery room records. And this is where it's good to document on the fetal heart monitor exactly when the fetus has delivered. So then you have a particular time. Provide immediate newborn care. Maintain warmth of the fetus, and we have to dry that baby off. We have to assess the newborn or the neonate's adaptation to extrauterine life. We do that APGAR score, and we'll talk about that more in the next module. Maintain a patent airway, provide safety and security. We promote paternal and or parenteral and newborn bonding, and assist the birth attendant as necessary. Now these next couple of slides show the fetal head crowning and actually beginning to deliver, and the support and guidance of the birth attendant as the fetus becomes a neonate. So now we've reached the third stage of labor, the delivery of the placenta. We still need to observe mom's psychosocial state and monitor for signs of placental separation. Some of these signs are we're going to have some increased vaginal bleeding as that placenta separates from the uterine wall, and the cord will begin to get longer coming out of mom's vagina because it is now pulling away from the uterine wall. And it can deliver in one of two ways. If you look at these pictures, number A is what we call the Schultz placenta. This is where the shiny side or the fetal side of the placenta comes through the vagina first. If you look at the second one, this is what we call a Duncan placenta, where the maternal side has come through the vagina first. It's then important for us to help prevent fluid loss. So we monitor vital signs every 15 minutes for a while. We're watching for shock. We're encouraging mom to drink fluids. We may give oxytocin at this time. It's going to help that uterus continue to contract, and as it contracts, then it constricts those blood vessels where the placenta was attached, and helps slow down or stop that flow of blood. Excuse me. And it's very important to watch for sudden changes in mom's status. So the fourth stage of labor is recovery. And this begins with the delivery of the placenta, and it ends when mom's physical condition has stabilized. She's at high risk for hemorrhage at this point. We need to monitor vital signs, monitor her lochia, which is the blood flow coming from the vagina. We monitor for signs of infection, urinary retention, pain, uncontrollable shaking in the lower extremities. That's usually due to hormones. And we monitor her psychosocial state. Very important to continue promoting parent-newborn attachment, minimize bleeding, promote urinary elimination, manage her discomfort, and reduce fatigue. So once again, true or false? The main priority of the nurse once the newborn is taken to the nursery is to apply the identification bracelet. This is false because we actually want to apply it prior to mom and baby being separated. And now your post-test.